When the CRL is greater than 84 millimeters, this implies a fetus, a pregnancy that is more than 13 plus 6 weeks, and in which case you use the head circumference as shown here with the ellipse in order to determine the gestational age. And this has been thought to be more reliable than using the biparietal diameter alone. So what about the number of fetuses present? And this is obviously when you're assessing a multiple pregnancy in order to determine the chorionicity and the zygosity. Now, briefly, chorionicity refers to your number of placentas, and zygosity refers to your number of zygotes. And it's essentially asking, are the twins identical? And I think in order to be able to determine this, you have to have, just a very brief reminder of the model of twinning. And you can see this here to the right. Your dizygotic twins are essentially two separate fertilization events that have occurred, results in non-identical twins that have two separate placentas. These are known as dichorionic, diamniotic twins. And these are identified by your lambda sign or the twin peak sign. You can see it here. You have this thick intertwin membrane that's divided by placental tissue, which is identified by this red dot. Conversely, you have your monozygotic twins, which results from post-zygotic splitting after a single fertilization event. And the stage at which splitting occurs essentially determines your chorionicity. When it occurs very early, so day 1 to 3, again, you get your dichorionic diamniotic twins as previously shown. So that's your lambda sign. If you have splitting a few days later, so between 3 to 8 days after fertilization, then you get your monochorionic diamniotic twins, and this is identified by what we call the T sign. So rather than having that thick placental tissue separating the two twin membranes, you've got a very thin intertwin membrane. So you can see that here. Later down the line, so now day 8 to 13, you get monochorionic monoamniotic twins, so a single placental mass and a single sac. And again, you can see here two twins that are separated, but there's no intertwin membrane. You get complete absence of that membrane. What I haven't shown, and is probably sort of later down the line, so that's after day 13, is your conjoined twins, which are obviously exceptionally rare. So the most important principle in learning obstetric ultrasound is really to be able to identify what is normal. When you scan 10, 20, 30 times a day, you become very astute as to what are the normal patterns that you need to be looking out for. And in doing that, it becomes very easy to then recognize when something is not quite normal, what deviates from your normal. And when you're learning how to scan, it's not necessarily to be able to understand what that abnormality is, but just first to identify that that abnormality is there so that you can find someone else who is able to help. Now, the issue recommendations for the first trimester scan include this whole big checklist of anatomy that you want to evaluate, and we'll fly through this checklist in the time that we have. And whilst doing so, we'll encounter some of the normal and some of the abnormal malformations that you might see along the way. Now, you'll start with the head. You'll examine the head in two sections. The first section is your sagittal section when you measure the crown rump length. So that's looking at the side of the baby. And in doing that, what you can see is you can see the cranial bones that go all the way around. And essentially what you're trying to rule out is this condition called acranioanencephaly. If you do a 90-degree turn of your probe, what you'll then get is this transverse section that you can see here in the picture. And again, you can see the cranial bones all the way around and this normal sort of butterfly or walnut shape of the choroid plexus. You've got a clear midline all the way going from back to front, separating the two hemispheres. And these two views will exclude the following lethal conditions. The first condition... Let me just mute. Thank you. Okay. So the first condition is acranioanencephaly sequence. Whether you call it acranio, whether you call it anencephaly, there's a lot of overlap in the literature. And essentially, this condition involves the absence of the cranial bones. You can see here on a sagittal section that there is no whitish continuity identifying the skull of this baby. And as such, the underlying brain is then exposed to the surrounding amniotic fluid, and you get deterioration of the brain tissue as the pregnancy advances. Now, these babies tend to survive the pregnancy, but generally they don't live beyond the first week of life. It's not associated with chromosomal conditions, and certainly recurrence in a future pregnancy can be reduced by advising the woman to take high-dose supplemental folic acid for at least 3 months prior to getting pregnant through to the first trimester. Moving on to the second abnormality, and this is really a whistle-stop tour through the first trimester scan. This is holoprosencephaly, and you can see, again, unlike that first picture that I showed you with the normal cerebral hemispheres, in this picture, you don't have the midline echo separating the two hemispheres from front to back. The lateral ventricles have not developed properly. They've completely fused in the midline, and so you have this single ventricle that goes all the way around. Now, there are 4 types of holoprosencephaly. The one that you'll probably see most often is what we call alobar holoprosencephaly, and this is typically associated with trisomy 13, also trisomy 18. And when you see these views, what's important is to really examine the rest of the baby, especially the face, because typically it's associated with other midline abnormalities and structural abnormalities elsewhere. The prognosis for holoprosencephaly, particularly alobar holoprosencephaly, is poor. Most of these babies, again, they don't survive the first year of life. So moving down to the neck, and of course, what you're measuring here is your nuchal translucency. And essentially, your nuchal translucency, or your NT, is a sonographic appearance of fluid behind the fetal neck. And this can usually be obtained in a fetus that measures between 45 to 84 millimeters, so before 13 plus 6 weeks. What are the criteria? There's quite strict criteria on how to measure the NT. And again, what you want is that mid-sagittal section. You can see the echogenic nasal bone here. You can see the rectangular palate here, and that's separate from your nasal bone. The image of the head and the thorax, again, is completely magnified, so it occupies your whole screen. And again, you want your fetus in the neutral position, so not hyperextended or hyperflexed. And the widest part of the nuchal translucency is measured using the inner border of your caliper, where you place it just on the line of the nuchal translucency thickness. Usually, we recommend that you take at least 3 measurements and you record the maximum 1. So we use a 99th centile cutoff to define an abnormal nuchal translucency, which corresponds to 3.5 millimeters or more. And the reason why we use a 99th rather than the 95th or the 50th threshold is because, as you can see on the graph to the left, the 99th centile doesn't change with the CRL within this range of between 45 to 84 millimeters. And of course, the larger the NT, the more likely there's an underlying chromosomal or structural problem elsewhere. Again, if you look at the table to the right, those with an NT of 6.5 or more, so that's really, really abnormal. Approximately 65% of those have a chromosomal abnormality, and of those that have a normal karyotype, approximately half have major structural abnormalities elsewhere. So again, it's not just the increased nuchal, but it's to what degree the nuchal is increased, and doing a systematic examination of the rest of the fetus. So moving on to the face, and again, this is a 90-degree rotation from your sagittal section, sweeping down the transverse section of the head. You see the 2 eyes here, so these 2 black circles with the whitish discoloration in the middle, which identifies your 2 lenses. The image at the bottom, this is a coronal section of the fetal lips. This can be difficult to obtain in the first trimester. Typically, you're more likely to get it in the second trimester, but if you are able to get it, certainly can exclude a major facial cleft. So to look at the spine, you need to have the baby lying on its tummy to make sure that you can see the spine all the way down from the neck to the caudal or the bottom end of the baby. You've got this nice continuous skin line that overlies the spine, and essentially what you're trying to exclude is an open-spina bifida. When I discuss the second trimester scan, I'll delve a little bit deeper into spina bifida and what that is. Moving on to the chest, and what you can see here is the gray areas of tissue that surrounds the heart. These are your lungs, and essentially what you're looking at is the echogenicity, the homogeneity of this gray tissue, making sure that there's no big black areas that might identify pockets of fluid or what we call pleural effusions or hydrothoraces. Now, when you examine the heart, and interestingly, Ishu are going to recommend to examine the heart in grayscale, I typically recommend applying Doppler in the first trimester in order to be able to demonstrate biventricular fill-in. What you can see here is, first and foremost, the heart is beating. Second, that the axis of the heart is correct. It's pointing off towards the left. And if you just pan down the transverse section of the baby, you can see that the stomach and the heart are correctly positioned on the same side of the baby. You've got 4 symmetrical chambers. And again, if you apply color or power Doppler, you'll see filling of these ventricles. So going down the bottom of the baby, you need to make sure that you can see the bladder properly. If it's empty, which sometimes it can be, then always go back at the end of your examination. Don't waste time during the examination trying to see whether the bladder is filling. Typically, by the end of your scan, the bladder will have filled. Now, it can be difficult to see the kidneys at this stage, but what you can see again are the 2 renal pelvises on either side. And again, if you apply color Doppler, what you'll see is the renal arteries, and this is on the coronal view of the spine. And next, you examine the cord insertion as shown in the lower image on your transverse section of the abdomen to rule out any abdominal wall defects, as you'll see over the next 2 slides. So starting with gastroschisis, this is probably one of the most common, and this is a defect in the abdominal wall, which is slightly below and to the right of the cord insertion. It tends to look a little bit like sort of seaweed floating in the amniotic fluid on your transverse section of the abdomen, and you can see that on the section to the left. Gastroschisis occurring a third, and fetal death, if the background rate is around 1% or less, again tends to be a little bit more common in those pregnancies that are complicated by gastroschisis. Ultimately, however, when you're seeing this in the first trimester, we tend to counsel them quite positively in that the prognosis and survival of these babies occurs in more than 90% of cases. In contrast to gastroschisis, you've got an omphalocele here, which again is a defect in the abdominal wall, but instead of it being free-floating intestine, it's covered by a sort of thin membrane of skin. What I would say is that you need to be careful to make this diagnosis prior to 12 weeks, because of course, in all babies that are prior to 12 weeks, you can get physiological herniation of the intestine. If you scan them a few weeks later, this will have completely resolved in almost all cases. And you can see here in the image to the left, this very classic appearance of omphalocele with a round protrusion from the abdomen containing intestine. And in this case here, on the image on the right, you've probably got liver as well. So unlike anomalies and about half, particularly cardiac defects. So again, if you see an omphalocele, you have to examine the baby closely elsewhere. Particularly, you have to evaluate for other body wall defects, because sometimes omphalocele can be part of a sort of much wider syndrome where you have herniation of the heart, impentology of Cottrell, and also herniation or extrophy of other structures like the bladder or the spine in neocloacal anomalies. The commonest chromosomal abnormality that tends to be associated with omphalocele is trisomy 13. And then final malformation identified on your examination of the abdomen is, of course, megacystis, which is defined as a longitudinal bladder diameter of 7 millimeters or more. Now, be careful when you see this in the first trimester and the bladder is measuring between 7 to 15 millimeters, because generally, if you scan them a couple of weeks later, it will have completely resolved. The cases where it doesn't tend to resolve are in those where the bladder diameter exceeds 15 millimeters. And this is typically because of an obstructive cause, like a posterior urethral valve in a boy or in a female fetus due to absence of the urethra. In those cases where the bladder is really distended over 15 millimeters, and again, the prognosis associated with this tends to be quite poor. It has a high perinatal mortality, and that's primarily due to pulmonary hyperplasia, because the large bladder causes splinting of the diaphragm and underdevelopment of the lungs, and of course, renal failure as well. So a lot of these babies will need dialysis when they're born. And then moving on to the limbs. So essentially what you want to be able to identify is that you've got 4 limbs, you've got 3 segments, and your hands and feet are in normal orientation. And again, I'm sometimes trying to be able to determine the orientation of the feet in particular can be difficult in the first trimester. Typically, this is more easily done in the second trimester. Okay, so we're at the end of the first. So at the end of Newton, sorry, one moment. We're at the end of the first trimester scan, and finally what you want to do is apply color Doppler as you're going down, as you're panning down the fetus to be able to demonstrate your 3-vessel cord, and then your longitudinal sweep of the uterus to be able to identify the position of the placenta. Now, by now, you're probably fed up. I'm not sure what you think, but it's a lot of information to be covering. And just at that point, what I'm now going to move on to is the second and third trimester scan. I think what I want to reiterate is that these slides will be available for you to refer, but also there are many guidelines that are available for you to read, and I would encourage you to read them because everything that I'm covering there are available in these guidelines in detail. So the whole purpose of these slides are really just to give you a framework to work on. Now, there are at least 3 guidelines that are published by ISHROG, which cover general anatomy in the second trimester, your biometry, and more detailed scanning of the heart and also the brain. But I guess, again, as with the first trimester scan, what you really want to ask yourself is, what is the purpose of the scan? Why am I doing it? When should I do it? And what are my aims? What are my objectives? So again, it's to determine the size. Is the baby too big? Is it too small? The position of the baby in preparation for birth, any placental anomalies, to identify any issues with the fluid volume, and furthermore, which is possible generally up until around 32 weeks, to evaluate the anatomy. So starting with the placenta, and these are the key questions that you really hope to answer with your scan. First, where is the placenta? Second, what is the relationship of the placenta to the internal cervical os, in particular, the leading or the inferior edge of the placenta? And finally, where does the cord insert into your placenta? So usually the placenta is assessed by transabdominal ultrasound. There are some cases where you need to use transvaginal ultrasound, but I'll discuss that later in the presentation. You can see here in the picture that this is an anterior placenta, and this is a posterior placenta, which can sometimes be a bit more challenging to see because, of course, you've got the fetal parts, which are causing lots of shadowing. So that's just these sort of black lines that are coming, sort of obstructing your view. And of course, at the top here, you've got what looks more to be a fundal placenta. Now, the method that we tend to use when we're trying to assess the placental position is to use 3 parallel planes throughout the maternal abdomen. We start from the top, we slide our ultrasound probe towards the maternal symphysis in 3 parallel sections. And this will give you a global idea of how the placenta is lying. Is it anterior, is it posterior, is it lateral, or is it fundal in the maternal abdomen? So next you want to identify and determine the relationship of the leading edge of the placenta to the internal cervical os, and you want to measure that distance. Now, a distance of 2 centimeters or more is considered high, as you can see here in the picture. So this is 3.41 centimeters. This is the leading edge of the placenta here, and you can just about see on a transabdominal image the internal cervical os here. This is your bladder. Okay, so you're measuring that distance, and any number which is greater than 2, you're happy that this placenta is not going to cause any issues for birth. Conversely, you've got here what we call a placenta previa. So you can see that, unlike with the previous image, the leading edge of the placenta completely traverses the internal cervical os, which is identified here. This is a placenta previa. And then finally, in the lower image on transvaginal ultrasound, you can see a low-lying placenta where the leading edge of the placenta is less than 2 centimeters from your internal cervical os. So you can just about see this sort of light grayish material. This is placenta. They've measured the edge to your internal cervical os, which is here, and that's just under 1 centimeter. Now, this image is extremely difficult to obtain on a transabdominal ultrasound. I mentioned earlier that there are some cases we use transvaginal ultrasound. This is probably it. When you have a posterior placenta and you think it's low, I would always encourage you to do a transvaginal ultrasound to be able to interrogate that a little bit more closely, because it can be exceptionally difficult with a transabdominal probe. Now, normally, as you can see here on this picture, the cord inserts into the central bulk of the placenta. So this is a normal central cord insertion. What are the abnormalities that you're looking for? And essentially what you're trying to rule out is a condition called vasa previa. And a vasa previa, for those who haven't heard of it, although I'm sure most of you have, is where the fetal vessels are running unprotected in the fetal membranes. So you can see, unlike the first picture where it's nicely inserted into the central mass of the placenta, here the vessels are running along, inserting at an angle to the placenta, and then coursing through the membranes. It usually occurs in association with a velamentous cord insertion. A velamentous cord insertion, as I've just said, is when the cord inserts at an angle into the placenta, typically into the membranes rather than the placenta itself. And it's actually identified here on this macroscopic to the right. You can see the cord is inserted into the membranes, and those fetal vessels are coursing through the membranes and into the placenta. Other situations where you can get a vasa previa are when you have a bilobed placenta. So again, if you have a bilobed placenta, I would always encourage you to rule out a vasa previa in addition to that. Prenatal diagnosis is important because when it's fetal death occurs in up to 60%, if not more, when the membranes rupture, causing damage to those fetal vessels, 36 weeks to avoid that complication. So moving from the placenta onto how we measure amniotic fluid. Now, there are two main methods that you'll probably read about in the literature. The first is when you measure the amniotic fluid index, or the AFI, and essentially what you do is you divide your maternal abdomen into 4 quadrants, and in each quadrant you place your probe perpendicular to the floor, and you measure the deepest vertical pocket that doesn't include umbilical cord or fetal parts. The AFI is then measured using the sum of these deepest pockets in all 4 quadrants. And this is an example here. If I've measured 3 centimeters, 6 centimeters, 4 centimeters, and 5 centimeters in the 4 quadrants, then the sum of those quadrants gives me an amniotic fluid index of 15 centimeters, which is normal. The second method is when you just use your deepest vertical pocket. And essentially that's where, again, you measure all 4 quadrants and you only use the deepest of those 4 quadrants. So in this example, my deepest vertical pocket here would be 6 centimeters because of all the quadrants that I've measured, 6 is the largest. Now, what's important, whatever method you use, is that you minimize pressure because, of course, if I press hard onto the maternal abdomen, what I'm going to do is underestimate the amount of fluid that is there. I keep my probe completely perpendicular to the floor. I don't angle it in one direction or the other. And essentially, it doesn't really matter what method you use in your institution. There's some evidence to say that if you use deepest vertical pocket, then you reduce the risk of an intervention without improving outcomes. So, but generally, the take-home message is that whether you use AFI or DVP doesn't really matter. And these are your definitions. You define polyhydramnios as a DVP of 8 centimeters or more, or an AFI of 24 centimeters or more. Oligohydramnios, which is reduced amounts of amniotic fluid, is defined as a DVP of 2 centimeters or more, or an AFI of 5 centimeters or more. So those are your cutoffs to identify either increased amniotic fluid or polyhydramnios, or reduced amniotic fluid, as with oligohydramnios. Now, what are the causes of polyhydramnios? And I was always taught in my training that essentially whatever causes a fetus to urinate more, so underlying maternal conditions like maternal diabetes results in fetal polydipsia, so you get increased amniotic fluid. Congenital infections, a similar mechanism, or anything that causes a fetus to swallow less, again, will result in polyhydramnios. So that's neuromuscular conditions, structural malformations like neck malformations, facial malformations, intestinal obstructions like duodenal atresia. And thirdly, anything which causes a hemodynamic fetal circulation, so that's your fetal hydrops and your fetal anemia. These are the causes of polyhydramnios. Now, this is by no means a comprehensive list. I'm sure if you go away, you could find 10 more, but they're most of the common causes that you'll see in the literature. And similarly with oligohydramnios, so that's a reduced amount of amniotic fluid that I've defined on the previous slide. The commonest cause, of course, is pre-labor rupture of membranes, but other causes that you need to think in the back of your head when identifying oligohydramnios on scan is placental insufficiency. So is this baby growth restricted? Is this baby small? What are the dopplers doing? And of course, abnormalities of the urinary tract, such as bilateral renal agenesis, multicystic kidneys, or urethral obstruction. Now, what's important to understand is that actually the amniotic fluid is really a combination of fetal urine, which is produced beyond 16 weeks. So prior to 16 weeks, the amniotic fluid is consistent from secretions of the placenta, of the uterus. But after 16 weeks, it's primarily fetal urine, which is contributing to your amniotic fluid volume. So Next session covers fetal biometry and the usual anatomical planes that we use to measure the head, the abdomen, and the leg. And these are the components that we usually use to calculate the estimated fetal weight. You can see here 3 images. The first image to the left is your head circumference. And again, this is what we call an axial or transverse view of the head. In the front of the head, you can see this box-like structure. This is your cavum, septum, pellucidum. From back to front, you can see your midline echo. And in the posterior part of the head, what you can't see is your cerebellum, because if you can see your cerebellum, then that suggests that you're too low. And essentially, these are the 3 anatomical landmarks that you want in order to measure your head circumference. What I did in training for obstetric ultrasound was divided my plane into 3 parts. So if I just use the abdominal circumference as an example, again, in the anterior third, what I can see is the umbilical vein as it enters into the abdomen and courses off to the right. I can see the stomach in the middle third of the abdominal circumference, and in the posterior third, I can see the aorta and the spine. And if I have these 3 structures in my anterior, middle, and posterior third of my view, then this is the correct, these are the correct anatomical landmarks that I need in order to measure the abdominal circumference. And again, just as with the head circumference, with the abdominal circumference, what you don't want to see are your kidneys, because if you can see your kidneys, then it suggests that you're too low down on the fetus to be able to measure the AC. And then finally, to the right, you have your femur length, and you can see both ends here are visible, and you can measure the femur from one end to the other. You can see the ossified diaphyses clearly. Now, if you have your femur angled too acutely, then typically what's going to happen is you're either going to over or under measure your femur length. So you want this 45-degree angle inclination to your probe. This is where you place your calipers. Now for the head and the abdominal circumference, you can use either an ellipse on your ultrasound machine as shown here, or you can take the diameters. So you can measure the bipyramidal diameter on the head and the occipitofrontal diameter, so from front to back. Similarly with the abdomen, you can measure front to back and side to side, rather than using the ellipse, depending on what function your ultrasound machine has. Now with the skull and with the head circumference, what you're measuring is outside of the bone. So outside of the bone to outside of the bone, not including the skin. And for the abdominal circumference, same thing, except with the abdominal circumference, you do include the skin on either side. So again, outer to outer, including both the bone and the skin. What you'll have on either side of the abdomen is a single rib, and femur length, both ends of the ossified diaphyses. Now, just even in taking your biometry, what you're able to do is identify really common anomalies. And I always say, whenever I'm doing a growth ultrasound, for example, typically I'll look for these structures. So just by measuring your head circumference, what you're first able to determine is the size. Is there any evidence of what we call microcephaly, where the head circumference is below the 5th centile? What does the shape of the head look like? Now, typically what you want is this nice sort of rugby ball shape skull. So it's narrower to the front, wider to the back. If you see this lemon shape abnormality, then this tends to indicate the possibility of an open spina bifida. The image one along is what we call brachycephaly. So you can see that the head is overly round. And at the bottom, you've got this sort of more elongated shape to the head. And that's what we call dolichocephaly. And you tend to see that in babies that are breech or bum down, or where there's a reduced amount of amniotic fluid, just because of the pressure that poses. And then again, what you can tell is the integrity of the skull. So are there any defects at any point around the skull to indicate the possibility of an encephalocele, where you have herniation of brain tissue out of a cranial defect? Moving along, abdominal circumference. Again, just by measuring your abdominal circumference, you can tell so much about the baby. So one, is there a stomach, the size of the stomach, and the position of the stomach? And you can see in this picture, you've got what we call a double bubble sign. If I go to my previous picture, what you can see is a single stomach bubble. Here, what you can see is 2. The one identified by S is your stomach. The one identified by D is your duodenum. And this is due to a duodenal atresia, resulting in what we call a double bubble sign. And tends to be associated with associated chromosomal conditions, like, for example, trisomy 21. Ultimately, because the fluid is not going from A to B, you get polyhydramnios, which is what you can see here. And then finally, your femur length. Again, just by measuring your femur, what you can look at is the integrity of the bone, the mineralization. Is there any bowing, as you can see in the top here? Are there any fractures to indicate the possibility of an underlying skeletal dysplasia? So what are your typical anomalies? And I'm going to, again, whiz through these just for the purpose of time. It's just, again, to give you a framework and understanding of the things that you might be looking for. So if we start with the head, generally speaking, there are two views that you want to obtain in examining the brain. So the first view at the top is your transthalamic view. Okay, so what you can see here is, again, your midline echo going all the way from front to back. This is your cerebri falx. You've got your ventricles, so your lateral horn, your posterior horns of the lateral ventricle here at the back. And again, you're measuring that. And then anteriorly, you can see this box-like structure, which is your cave type. And again, this is in the anterior part of the brain and looks normal. So these are the structures that you're looking at in your transthalamic view of the brain. Now, when you measure the ventricles, essentially what you want to do is measure the inner parts of the ventricle, so it's inner to inner. You want to keep it perpendicular to the long axis of the ventricle, and generally speaking, you want it to be less than 10, but I'll show you this on the next slide. Your second view is a transcerebellar axis of the brain, and again, what you can see is your cerebellum. You can see the cisterna magna, which you want it to be less than 10, and you can see your nuchal fold, which is the what's left on your nuchal translucency posteriorly. And these are the three measurements here. So your cerebellum is measured here posteriorly, your cisterna magna is measured from here to here, and your nuchal fold, again, just as you would measure the nuchal translucency, but this time in the transverse section. So what are the common abnormalities that you might see in examining the brain? Ventricular megaly is one of the most common referrals that we have. About 1% of fetuses will have this at their 20-week scan, to various degrees of severity. So mild is where the ventricles measure anything between 10 and 12. Moderate is between 13 and 15. And severe is when the ventricles measure greater than 15. And there are multiple causes. So when I'm discussing this with women, I'll take them through possible chromosomal or genetic abnormalities that are associated with ventricular megaly, intracranial hemorrhage, which causes obstruction and then dilatation of the ventricles, congenital infections, so commonly things like CMV, toxo, and obstruction either due to a malignancy or, as I've already said, a hemorrhage. Type of investigations that you might want to do is often an invasive test in order to be able to rule out a chromosomal condition, a torch screen, again, trying to rule out infection, antiplatelet antibodies as a possible cause of hemorrhage. And then later in the pregnancy, depending on where in the world you're scanning, fetal MRI to look at the surrounding brain tissue. Generally, we scan them every 2 to 4 weeks to monitor progression. And if it remains mild, I tend to be fairly reassuring in terms of the prognosis, in that, generally speaking, the risk of neurodevelopmental delay is between 5 and 10%, which is similar to your general population. If you have moderate ventricular megaly, then the risk of neurodevelopmental delay is slightly greater, around 15%. And although the literature is not that extensive in the context of severe ventricular megaly, around half of these babies will have neurodevelopmental problems as they grow older. So moving on to the face, and essentially, again, this is a coronal view that I showed you from the first trimester, but much easier to obtain in the second trimester. And you can see the tip of the nose, you can see both lips. And again, what you're trying to do is identify the integrity. So there's no evidence here of a facial cleft. You've got your mid-sagittal view, which is looking at the facial profile. So no evidence of frontal bossing. The forehead is in line with the rest of the face. Oh, I've skipped ahead. You can see the nasal bone, and again, no evidence of micrognathia. And then you've got your axial view of the face, looking at both orbits. You can see that whitish discoloration here on both sides is the lens. The other aspect that you're looking at in the eyes is that, generally speaking, you want to be able to fit a third eye in between. If you cannot, then it suggests that the eyes are too close together. If you can fit more than one eye in the middle, then it suggests that the eyes are too far apart, which might indicate problems elsewhere, as I'll show on the next slide. So what are the abnormalities that you're looking for? As I've mentioned, on that coronal view, what you can see here, tip of the nose, you can see that the integrity of the top lip is broken, so there's a cleft, bottom lip is intact. On the middle slide, Again, this is your sagittal section looking at the facial profile. What you can see is severe micrognathia. So you've got regression of the chin. And on the third image, again, looking at the eyes, what you're looking for is either hyper or hypotelorism. So hypertelorism is when the eyes are too far apart. Hypo is when they're too close together. Or you're looking for anophthalmia, which is complete absence of the eye, or microophthalmia, which is where you've got a small eye, as seen on the image here. So this is an image of a baby that's got microophthalmia. The eye on the right is much smaller and hasn't developed as the eye on the left has. And again, usually that's indicative of chromosomal abnormalities or structural problems elsewhere. So just a brief word about cleft. Whenever you see a cleft, what you really want to ask yourself is first, is it unilateral? Is it bilateral? You can see a unilateral cleft here, which is highlighted by yellow with the yellow circle, compared to a bilateral cleft where you've got a much wider defect. Unilateral tends to be the most common, and with unilateral clefts, it tends to be on the left side rather than the right. The second question you want to ask yourself is it syndromic or is it non-syndromic? And essentially, in asking yourself that, you're asking, are there structural problems elsewhere? So syndromic tends to account for about 30% of clefts. Usually it is bilateral, and usually it is associated with chromosomal problems structural problems elsewhere in the baby. I haven't listed all the syndromes that are associated with cleft because there are many. The one that we most commonly see here is 22q11 deletion syndrome, or DeGeorge, as it was previously known. Non-syndromic, however, is much more common, and it accounts for 70%. And of those that are non-syndromic, you want to ask the mother, does she have any history of drug abuse, alcohol, underlying comorbidities like diabetes make the pregnancy much more prone to having complications like cleft? Do they smoke? And also, is there any family history? Because you can see that if the parent has had cleft, then the baby's at a much higher risk of having a cleft itself. Equally, if a parent and a sibling has previously been affected, then a recurrence of about 20% in another pregnancy it tends to be seen. And in terms of how you manage cleft, it's multidisciplinary team input. So usually it's just about trying to support the baby with feeding following birth. They don't tend to have an operative repair until at least 3 months of age. You can offer invasive testing because, as I've said, especially if there's structural problems elsewhere, then this does tend to be associated with chromosomal abnormalities. And even if the karyotype is normal and the baby is otherwise well, then common comorbidities, because of the anatomy of the face, tends to include things like eustachian tube dysfunction and impact on speech development later in life. So moving on from the face to the thorax, and again, what you're trying to do is trying to visualize the integrity of the diaphragm that you can see here. So this sort of light gray homogeneous material is your lungs, and then below what you can see is bowel, stomach, and liver. So you're looking at the texture of the lungs. Again, you're looking for any masses, any areas of fluid collection, as demonstrated by big dark areas, and that integrity of the diaphragm as you pan through the baby from right to left, trying to rule out essentially what we call the congenital diaphragmatic hernia. Now, as the name suggests, a congenital diaphragmatic hernia is where you get herniation of abdominal contents into the thorax due to a defect in the diaphragm. It typically occurs on the left, so you have herniation of the stomach and intestine into the thorax. When it occurs on the right, you get herniation of the liver up into the thorax. And this is an incredibly difficult pathology to identify on scan. Usually the way that you identify it is because the axis of the heart is completely deviated as a result of it being pushed from one side to the other from the abdominal contents. When you do recognize it, you have to counsel the woman that there is a possibility of it being associated with a chromosomal abnormality or genetic syndrome. Additional malformations elsewhere in the baby occur in around a fifth. And then you have to assess severity, because the severity of the hernia will determine prognosis. And the way that we determine severity is by measuring what we call the observed to expected lung-heart ratio. Now, the way that you do that is that you obviously measure the head circumference as per normal, and then you measure the contralateral lung area in your axial section of the thorax. So that's measured here. So this big red thing, you've got the heart, you've got the stomach, which has come into the thorax, and you're measuring the right lung, which is sort of pushed down and squashed as a result of herniation of the abdominal contents and deviation of the lung. Now, essentially, the smaller the contralateral lung is, the worse the prognosis. And that's as a result of what we call pulmonary hyperplasia. So the lungs are underdeveloped. You can't ventilate them when the baby is born. Now, when the OE-LHR is less than 25%, this indicates severe. When it's 26 to 45%, it indicates moderate. And when it's more than 45%, it indicates mild. And you can see the survival here, depending on whether it's severe, moderate, or mild, is summarized. So in those that have severe congenital diaphragmatic hernia, then less than 25% of these babies will survive, compared to when they have mild, where 85% of these babies will survive and require operative repair when they're born. Okay, so moving on to the heart. Now, I know that in the timetable, there is a session that's dedicated purely to the heart. And so what I'm going to whip through the 5 recommended screen and views. By no means do I expect that you're going to be able to go away and then scan the heart following this, but again, it's just to understand the theory behind what you're doing in the practical sessions. So the first view is really to confirm laterality. So are the stomach and the heart located on the left of the fetus? And again, in order to do this, you need 2 views. You need your axial section of the abdominal circumference, as I previously showed, and you need your 4-chamber view, as I'll show you on the next slide. Here you can see your axial section. You've got your stomach to the left of the baby. You've got your aorta, which again is always slightly to the left. And you've got your IVC, your inferior vena cava, which is slightly to the right. And again, you then scan up. You get your 4-chamber view of the baby. Knowing the position of the fetus within the maternal abdomen, is a baby head down or head up, you'll be able to confirm whether the stomach and the heart are located towards the left of the fetus. The second view, so again, what you're trying to then establish is to look at the 4 chambers, is what we call the 4-chamber view. And what you're trying to establish is the axis of the heart correct? So you want it to be 45 degrees deviated towards the left. Does it occupy 1/3 of the thorax? Is the left ventricle apex forming? And then you can see the right ventricle has a slightly sort of thickened band. This is called the moderator band and is quite typically seen, because remember, this is the one which is doing most of your work in the fetal circulation. You want the 2 ventricles to be proportionate. So does the right ventricle and the left ventricle equal in size? And then the other aspect of the 4-chamber view that you're looking at, which you want to really confirm, is that there is offsetting of your atrioventricular valves. And essentially what that means, if you look at your tricuspid valve, if you look at your mitral valve, it's not completely on one level. The mitral valve is slightly higher, as you can see here, than your tricuspid valve on the right. Okay, and this is what we call offsetting. Okay, so if it was completely flat, if they were all on one level, then what I would say is that there's evidence that there is no offsetting, and that can be an indication of an underlying structural problem with the heart or chromosomal issue like trisomy 21. Typically, what I then do is apply color Doppler. And again, what you can then see is biventricular fill-in on both sides. The third view is what we call the left outflow track. And in this view, what I really want to be able to determine, does the aorta arise from the left ventricle? Okay, as I can see here. So I can see that the aorta is continuous with the left ventricle. Does it have an aortic valve? So you can see that on the middle image, there's whitish discoloration, and you can see it opening and closing when you take your video. And is there what we call laminar flow during systole? So you can see, for lack of a better way of saying it, that the blue is homogeneous all the way through this aorta. When it lights up bright, this is what we call aliasing, and indicates that there might be turbulent flow through the aorta as a result of obstruction like aortic valve stenosis. The next view is what we call the right outflow tract. So remember, we've assessed your aorta on the left. What we want to then look at is your pulmonary right. And you do this with what we call the 3-vessel view. I'm sure you've all heard of this. And again, the question I'm trying to ask myself is, does the pulmonary exit from the right ventricle, and does it bifurcate into the left and the right pulmonary arteries? Does it have a valve that opens and closes? So again, at the top here, what you will be able to see is that whitish little valve opening and closing on your video. And is it positioned slightly to the left and more anterior to the aorta? So aorta is this middle bubble here. All the way to the right, you have your superior vena cava. So your superior vena cava, your aorta, and your pulmonary. The pulmonary is slightly anterior and more towards the left of the aorta, okay? And in doing so, you can determine that the great vessels are correctly aligned. You're ruling out an underlying condition, like, for example, transposition of the great arteries. And then finally, your right outflow tract. So this is your 3-vessel and trachea view. So I've confirmed aorta comes from the left, pulmonary comes to the right. There's bifurcation of the pulmonary aorta. The vessels are correctly aligned. What I'm then looking to see is the direction of the ductal and the aortic arches, okay? And then what you can see is this sort of V-shaped sign. So again, you've got your ductal arch, which continues into your pulmonary, and you've got your aortic arch continuing into your ascending there, okay? And then finally your SVC. And again, if you apply color, this gives you what we call the V sign, okay? And in having this view, what you can then confirm is that you've got antegrade flow. So essentially the color will either be all blue or all red, depending on the direction of your probe, direction of your fetus, to determine that the blood is moving in one direction. You're not getting backward flow as a result of an obstruction in the aorta or the pulmonary. Okay, so that's the heart. And the heart is probably the most complex. I remember when I was learning how to scan, I thought, how am I ever going to understand how to scan the heart? But especially if the baby's in the correct position, essentially what you're doing is just adding the probe all the way up the baby in order to obtain those views. And again, it's just doing it day in and day out, multiple times to identify what's normal, to then be able to identify what's abnormal. So moving on to the abdomen, and this is very much similar to the first trimester, you'll be pleased to know. Essentially what you're looking at is the integrity of the abdominal wall. So you can see that here, identified by the white arrow. So the cord inserts into the abdominal wall. You can't see any overlying defect. There's integrity of the overlying skin. Okay, you're looking at your kidneys, and in the mid trimester and the second and third trimester, you can assess your kidneys on an axial view of the tummy, and essentially what you're trying to look at are your renal pelvises. These are here identified in black. In addition to identifying that the baby has 2 kidneys, what you also want to be able to exclude any underlying neuropathy, and the way that you do that is by ensuring that the renal pelvises are not dilated to a diameter of 7 millimeters or more. So here you can see that they're nice and slim. There's no underlying problem here. These kidneys are nice and healthy in size and echotexture. And then moving to the last slide, again, you can see that the baby has a bladder. That bladder is not enlarged. And if I apply color Doppler, what I can see is the umbilical artery on either side, confirming the presence of a 3-vessel cord. Moving on to the spine, and essentially you want to be able to view the spine in three planes. So I've got my sagittal view of the spine. I can see overlying skin all the way down from the cephalic end all the way to the bottom of the baby, hopefully excluding an underlying open spina bifida. Genesis, and generally speaking, the way that you're going to identify a spina bifida is actually by your cranial signs rather than the spine itself. And the cranial signs that you're looking at for are as defined by Professor Nicolaides, the lemon sign. So you've got this sort of lemon shape of the skull. You've got the scalloping of the frontal bones. And the banana sign, where you can see that the cerebellum is being pulled inferiorly as a result of the herniation of the spine. That's what we call the banana sign, okay? And it's your Arnold Chiari type 2. You've got complete obliteration of the cisternum magna. So again, going back to my normal view of my transcerebellar plane, usually you've got this beautiful sort of fluid-filled section behind the cerebellum that's completely obliterated, and the cerebellum is pulled back, okay? And then, of course, you can observe the lesion directly on your sagittal view of the spine. And then your sort of downstream effects of the open spina bifida are things like talipes or clubfoot as a result of your neuromotor dysfunction in the lower limbs caused by the spina bifida. Now, associations tends to be commonly seen as a malformation in women who have poorly controlled diabetes. Some anti-epileptic drugs tend to be associated with spina bifida, and about 10% of these babies will have an underlying chromosomal abnormality like T18. Moving on to the extremities, and again, much like with the first trimester scan, what you're trying to do is confirm that the baby has 4 limbs and that they have the 3 appropriate segments to each limb. So obviously you've got your humerus, your ulna, your radius, and then in the lower limbs, you've got your fibula, tibula, and your femur. You're trying to confirm that these bones look appropriate in integrity. There's no evidence of fracture or bowing, and the hands and the feet are correctly aligned. Okay, we're almost there. The last part to talk about is your dopplers. This is a schematic view of the diaphragm or the placenta. I'm sorry, myself, I'm starting now to get confused as to the parts that I'm looking at, but this is the placenta. And essentially what you're trying to understand is the interface between the fetal and the maternal side. Now, your maternal dopplers that we tend to interrogate are your uterine arteries, and the fetal dopplers that you tend to interrogate are the umbilical and the middle cerebral arteries, ductus venosus, and the umbilical vein, which we tend to use less commonly. For the purpose of this presentation, for the purpose of basic obstetric ultrasound, the two that we're going to concentrate on are the umbilical arteries and the uterine arteries. So starting with umbilical, and essentially what you want to try and obtain is a free loop of the cord. Again, you want to zoom in, you want to maximize that image. You want to make sure that the segment of the cord that you're interrogating is not too close to the abdominal insertion site, because then what happens is your resistance is falsely elevated, or that it's not too close to your placental insertion site, because again, it might result in a underestimation of your Doppler. So you really want a nice free loop somewhere in between the placenta and the abdomen, which is what you're going to then measure. You don't have to apply color Doppler, but quite often it's easier if you can. And then you place your sample gate, as you can see here, over the umbilical artery in order to then measure. And this is the waveform that you should obtain. Sometimes if you have breathing movements, if you have activity, then you don't get this nice sort of regular waveform, but certainly that's what you're trying to get. And these are the different Doppler patterns that you might see. So in the normal image to the left, what you can see is there's nice forward flow, nice regular wave pattern. So this is a nice healthy placenta. In placentas that are at risk of placental insufficiency, fetal growth restriction, then what you tend to find is stiffening. And stiffening of the placenta is highlighted by an increase in the resistance of the umbilical artery. And there's a steady progression. So what you would then find is high resistance, high pulsatility index is your marker of resistance. So you can see that in diastole, the amount of forward flow is greatly reduced when you compare it to the image to the left. And this becomes so severe that you then get absent diastolic flow completely, followed by reversed end diastolic flow in the image all the way to the right. So this tends to be the progression of the umbilical artery Dopplers that you'll see from a nice healthy all the way to one that is severely growth restricted, requiring delivery fairly imminently. Now, the progression in these Dopplers tends to be fairly predictable. In a woman that doesn't have preeclampsia or any other significant hypertensive conditions like chronic hypertension, generally speaking, from the point at which you have high resistance to the point where you get reversed, you've got about sort of 5 to 6 weeks of that pregnancy left. And that tends to be much more accelerated in the context of women who have preeclampsia. And then finally, uterine artery Dopplers. So these are your maternal Dopplers. And when you have increased resistance within the uterine artery Dopplers, that tends to be associated with adverse pregnancy outcomes like fetal growth restriction, preeclampsia. And the degree of abnormalities within this uterine artery Dopplers tends to predict the degree of severity in either of those conditions. Now, again, I'm sure I don't need to revise the pathophysiology of preeclampsia and fetal growth restriction, but generally speaking, in a healthy pregnancy, what you tend to expect are that the uterine arteries change from high resistance, low capacity vessels, as illustrated here in the top left-hand corner, to low resistance, high capacity vessels, as illustrated here in the bottom, by the time you get to around 20 to 22 weeks. Placentation starts between 8 to 10 weeks. So as I said, at that point, the uterine arteries are still very constricted, they're still very narrow. But as a result of the maternal adaptations that happen in pregnancy, those vessels become nice vasodilated to be able to support the uteroplacenta unit as the pregnancy advances. That would be the normal progression that you would expect. The second wave of placentation is generally concluded by around 20 to 22 weeks. So by that point, your uterine arteries are what they will be. Now, where you get a failure of this vascular transformation identifies, as I said, those pregnancies that are at risk of complications as a result of placental insufficiency, such as preeclampsia and fetal growth restriction. And it identifies those women who you need to say, well, look, you need to monitor your blood pressure more frequently. We perhaps need to do more frequent fetal growth scans to be able to identify either of these conditions. How do you measure it? Generally speaking, we tend to do transabdominal uterine artery Dopplers. They can be measured transvaginally, but as I said, generally we're able to measure them transabdominally. You identify your external iliac vessels that you can see here crossing, and you sample. So you place your calipers about 1 centimeter downstream from that crossover point. So that's highlighted by the white X. Okay, so these are your external iliacs. You're measuring your uterine about 1 centimeter low down. And the reason we set this criteria is primarily so that there's standardization in the way that you're measuring your Dopplers. So when I measure the Dopplers and someone else measures the Dopplers, we're getting the same value. Essentially, we measure the left and the right separately. And depending on where you work, depending on the institution that you're in, you might use different cutoffs. So at UCLH, we use a combined PI of 2.5 or more to identify those pregnancies that require closer surveillance. Other institutions might use a mean pulsatility index of above the 95th centile or the presence of notching to indicate those pregnancies that need closer surveillance. So again, it's just about deciding within your institution what the criteria for abnormal you're going to use. And when you identify uterine artery Dopplers that are abnormal, and I'm talking about mid-trimester, so I'm not talking about first trimester uterine artery Dopplers or third trimester uterine artery Dopplers, but mid-trimester abnormal uterine artery Dopplers, then generally speaking, the likelihood of that pregnancy being complicated by fetal growth restriction is about 30%. The likelihood of that pregnancy being complicated by preterm preeclampsia is about 50%. And really, at this point, there's not much that you can do. We know that aspirin prior to after 16 weeks doesn't work. And so really what it's about is surveillance. So that's a whistle-stop tour through first, second, and third trimester ultrasound. It's a lot of information. I would encourage you, as I said, to really look at those guidelines. I'm sure some of us are feeling that we've sprinted to the finish line and we're happy and we've absorbed all of it and we're now experts in obstetric ultrasound. Others perhaps feel a little bit less optimistic and wonder how they'll ever understand all of this information. Certainly this is how I felt many years ago when I was training. But really what you have to do is put it into practice. It is about, scanning, and scanning some more in order to really sort of apply this theory and understand how it all works. What I hope we've achieved in this lecture is covering really the basic theory between first and third trimester ultrasound, really sort of from top to toe. I'm happy to answer any questions or hand back to Dr. Eager.
I think she deserves a big round of applause. Well, this was more than I expected. I think you had less than 2 weeks. And to imagine that you put all this within 2 weeks, it's something that I really appreciate. I obviously keep telling every person that for the little time that I have met Diane, I've not had to regret it. at every instance is always available and willing to assist and to help. In just a short time, she had made up her mind that she would be available for this year's workshop, but a few things came up, and so she couldn't make it, and she decided to join us online. It's been very fantastic. This lecture actually sets the tone for the entire program. You've gone from head to toe, as you said. You've gone through everything: cardiac, neurosonogram, dopplers, fetal anomalies, everything, even the things that sometimes we'll say, oh, this will be too much for this lecture. You've given us something to really ponder about. So I want to tell you that I am extremely grateful. We all are very grateful to you. I try to get the recordings for this, so I'm going to put them together, put them on our TV, and so that people would be able to listen subsequently. I'll probably get the slides too, and then we can share it with our participants. This is just tip of the iceberg for every person. I think I can stop